begin the program.
Okay.
And continuing nursing education program, which is basically to improve improve learning of nurses in neonatal intensive care units. So this program is usually conducted every 2 weeks on a Friday afternoon, 4 to 5 p.m. So if you have any nursing friends amongst the viewers, you're please welcome to encourage them to join this program. So we during this program, please everybody stay mute, and if you have any questions, you can definitely pop them in the chat box. We also have a live YouTube link, so in case the number of viewers are more than 100, and if somebody drops out, you can still join us on YouTube live. So this program will be live on YouTube, and you can also watch the recorded sessions later on in your free time in case you missed the program. So today we have two interesting topics. Both of them are related to ventilation, where one is the assisting intubation, and then the second one is nursing care during ventilation. So I'll invite Dr. Jaisal to introduce the speakers, to introduce the expert, and so that we can begin the session. Thank you, Dr. Jaisal.
Good afternoon, everyone. So आज बहुत तो इंटरेस्टिंग टॉपिक रोज का ब्रेड एंड बटर है। हमेशा हम देखते हैं कि जब डॉक्टर्स और नर्सेस दोनों का जो जॉब होता है वो डिफरेंट होता है। तो डॉक्टर्स आर डूइंग द प्रोसीजर्स एंड नर्सेस आर देयर टू असिस्ट सपोर्ट टू ऑप्टिमाइज द चांस टू सक्सीड। और सो आज का जो पहला टॉक है वो है ऑन द हाउ टू असिस्ट डॉक्टर फॉर द इंटुबेशन प्रोसीजर। और जो दूसरा टॉक है वो है विच इज द वेरी इंपॉर्टेंट थिंग केयर ऑफ ए वेंटिलेटेड न्यूनेट। फॉर दैट आई विल लाइक टू एक्चुअली इनवाइट आवर एक्सपर्ट डॉक्टर सुनील। हैव यू जॉइंड? Dr. Sunil is going to join in probably 2 minutes. He's just clicking on that. So the expert moderator is Dr. Sunil Khwane. He is a head NICU as well as he is a practicing neonatologist in Aurangabad MGM Hospital. And he has done his pediatrics as well as the neonatal DNB. वो बहुत सारी conference में he goes to educate and give talks, and he is also a very great academician. So we welcome him, and hopefully he I just spoke to him. He's joining, and with that I will like to invite our today's. He joined. Okay, Dr. Sunil, would you like to introduce? Hi, welcome. I just gave your introduction. Welcome. Would you like to introduce our both the experts?
Yes, ma'am. Sure. Thank you. It's my pleasure to introduce both the eminent speakers today for today's talk. One is our own Fanish Kaushik sir. I know him personally, so no need of introduction. But for others, he's a intensivist, I can say, and he's in charge of NICU and PICU at Sanjeevani Children's Hospital, Aurangabad. He's doing intensive care for almost, I can say, more than 2 decades now. And definitely for this topic of intubation, this is going to help us. His experience and his words of wisdom is going to help us. Second speaker for today's talk is she's Tino Anu Matthew. So Anu Matthew, I think it can be. So she's in charge nurse, and she has done a GNM, and she's looking after NICU and PICU. So it's a very great combination of pediatrician and a sister in charge of NICU, and to listen from them about the intubation, like assisting intubation and its nursing care and nursing care for ventilated neonates. So I hope like others also will get a lot of insights about how to go ahead with this intubation part in NICU, and how the nursing and pediatrician as a team, how it will help us, and how like you can say like checklist sort of or customize or something, like if you have protocolized way for going ahead with intubation, neonatal plan intubation, how it will decrease the errors and how it will improve the quality. So without wasting much time, with permission from Madam Jesselman, I will ask our Fanish Kaushik sir to start with the first talk.
Sir, over to you.
Yeah. Thank you, Sunil. Hello. Am I audible to you?
Yes,
You're
sir.
audible.
We can hear you.
So thank you, Sunil, for the introduction, and I thank the organizers for giving me an opportunity to talk to the nurses. आप सबको मालूम है कि without nurses, outcome in NICU is always compromised. So the better the nurses are, and the better the quality of nursing in the NICU, the outcome is always the best. So regarding this today's topic, endotracheal intubation. So actually endotracheal intubation होता क्या है कि basically we put in a tube into baby's airway, and then we can use that tube to ventilate the baby or to give some medications like surfactant or so. So where all do we need intubation? We can need intubation either in the delivery room when the baby doesn't cry and his breathing is not improving despite giving positive pressure ventilation with the ambu bag. That time we have to intubate a child and give him breaths. Or in NICU, when sometimes you have to give some medications like surfactant, or baby suddenly collapses, then also baby will require intubation. So regardless of the indication for intubation, we are basically today going to focus on the procedure itself and the problems that we can encounter during the procedure. So just a minute, I'll just share my screen. Am I visible properly, ma'am?
Yes, sir.
Hello.
Yes, sir.
Yeah. So, so in for intubation, what indication we have just seen. So, what are the things that we need for intubation? So, the most important thing that we need for intubation is the endotracheal tube. So, I have kept these three tubes which are there: 2.5, 3, and 3.5 here. For intubating the child, what we need is a laryngoscope. The laryngoscope can be seen. Along with that, we need different sizes of these blades. So if you can see these blades, size 1, size 0, and size 00. Size 1 is for the term newborns, 0 is for preterm babies, and 00 is for extremely preterm babies. Along with this, what we need is extra set of batteries, because many times ऐसा हमेशा होता है कि इमरजेंसी में वो लैरिंगोस्कोप का बल्ब नहीं काम कर रहा है, लाइट नहीं चल रहा है. So you should always keep these extra batteries, set of batteries in the place where you are going to keep all these things. Plus what we need is these extra bulbs, because many times laryngoscope ka blade is only not, bulb is not only functioning, right? Along with that, what we need is a ambu bag, along with masks of different sizes for term and preterm babies. With this, we need a scissor and a tape for fixing the endotracheal tube, a stethoscope to ascertain the breath sounds on either side, then different sizes of suction catheters we need, right? For suctioning the pharynx and through the endotracheal tube, we need different sizes. What different sizes, that we'll see later on as we progress ahead. Then we need a stethoscope, I said, and along with that, sometimes what we need is a stylet for assisting the intubation. So the most important part of this thing is endotracheal tube. Now this is an endotracheal tube. So what is an ideal endotracheal tube? We should never use, remember not to use a red rubber catheter tube, right? What we are advised to use is this, the Cortex disposable tube, right? The ideal endotracheal tube should be uniform in length. It should not be cuffed for the newborn babies, and it should have markings centimeters mein. And along with that, there are, this is a dark lines which you can see at the end of the tube. These are called vocal cord guides, right? So this is the endotracheal tube. So what we have is a baby who is less than 1 kg will require a 2.5 centimeter ka endotracheal tube. 1 to 2 kgs is three size ka endotracheal tube, and more than 2 kgs we can have a 3.5 or a 4 size ka endotracheal tube in this. So once we have selected the proper endotracheal tube according to the weight of the baby, similarly according to the gestational age also we can decide which size endotracheal tube is going to be needed. So the rough formula for that is gestational age divided by 10 is the rough estimate for the endotracheal tubes. For example, a 30-weeker baby is going to be born, so divided by 10 is 3. So roughly we will require around 3 size ka endotracheal tube for intubating this baby. So once we have decided the endotracheal tube size, then we have to decide how much length are we going to put it in, right? So for that, what we can do is we can measure the distance from the nasal septum to the tragus, that is in centimeters, add 1 centimeter to that. So say this distance from nasal septum to tragus is around 8 centimeter, add 1 more centimeter, that becomes 9 centimeter. So 9 centimeter should be the marking at the upper lip of the baby when we insert the tube into the baby's trachea, right? So this is what we have decided. Now, once we know that we are going to insert up to say 9 centimeter, then we go on to the checking the laryngoscope and its functioning. Before intubation, we have to check that the laryngoscope is functioning properly. For that, what you need to do is you take a laryngoscope and snap the blade into its place and then open it into the on position. We should be able to see the light comes. Sometimes what happens if this bulb is loose here, then we have to tighten it, or if it is not functioning, we have an additional bulb. We should always keep it handy so that it doesn't function, it doesn't malfunction at the time of intubation. So once we have checked, and depending upon the maturity, we have decided if it is a full-term baby, going to be a 1 number ka blade. If it is a preterm, then 0, and if it is extremely preterm, 00 blade can be used for intubating the child. Then simultaneously we have to check for the ambu bag also if it is functioning properly or not. For that, we all know you fix a mask, fold it tightly against your palm and give 2-3 puffs. This should basically ascertain that the self-inflating bag is coming back to its original shape properly, and this pop-up valve is also functioning properly. So this has to be ascertained before we intubate a child, right? Then we have to keep the sticking cut for fixing the endotracheal tube at the end of it, at the end of the procedure. So the tape can be cut like this in a pant-like shape and kept it ready at the side. Along with that, we should have a O2 pulse oximeter to check for the saturation of the baby. We should have a stethoscope to check the heart rate and breath sounds whenever we are doing this procedure. Most important thing is we should have aseptic precautions. For that, we need sterile gloves also. Remember, this is you are invading into the baby's mucosa. तो ऐसे नहीं होगा कि आपने ऐसे ही अंदर घुस गया और इंट्यूबेट कर दिया. Especially when it is not an emergency, when you want to give surfactant and all that time you should take all the aseptic precautions. And even before delivery, we should we take aseptic precautions. Wash your hands properly, put on gloves, mask, gown, and then wear proper sterile gloves, and then only intubate a child. This is to prevent the infection in the baby. So once all this preparation is in place and we know we have selected the proper size of the endotracheal tube, we have decided the insertion length of the endotracheal tube. According to the this thing, for doing suction also we have to decide which size of suction catheters that we are going to use. We use around 8 or 10 or 12 French suction catheter for suctioning the oropharynx, right? And for suctioning through the endotracheal tube, if it is 3.5 centimeter or 3 centimeter endotracheal tube, then we'll need a 8 French suction catheter. And if it is 2.5, then we'll need a 5 or 6 French suction catheter for suctioning the tube. While doing suction, few things are important. We should not proceed beyond the tip of the endotracheal tube when you insert a suction catheter into the endotracheal tube. And then for that, what you do is, where we have calculated the nasal septum to tragus ka length, plus we have added 1 centimeter. So that much we are going to put in the endotracheal tube inside, right? Along with that, whatever is the amount of endotracheal tube which is going to remain outside baby's mouth, so you add these two distances, and this total length, suppose 9 centimeter we had decided we are going to insert the endotracheal tube, and around 5 centimeter the tube is going to be outside the baby's lip. So 9 plus 5 is 14. So we should not go beyond, say, 13 or 13.5 centimeters into the endotracheal tube if you are going to do suction. This should be decided even before the do the intubation of the child. Now, when we'll come to the endotracheal intubation procedure, when we are decided to intubate the child, the position of the child is most important. The position should be such that the baby's head, it comes to around the person who is going to intubate the child, uske upper abdomen या lower chest तक baby का head आना चाहिए, right? And the baby's head should be kept in the sniffing position or neutral position. So neutral position, say, what do I mean is that baby's head should not be either overextended or flexed. If the baby's neck is flexed and if you try to intubate, तो आपको क्या दिखेगा? Only posterior pharyngeal wall you will see. And if it is overextended, तो ये larynx जो है, it gets pulled up and you will not be able to see the vocal cords or the glottic opening in there. So the child's head should be placed in the neutral position. So this is the most important step, because if you don't give proper position, तो आगे का intubation is going to be very difficult and you might require repeated attempts. So the position should be this thing. So to achieve the sniffing position, what we can do is we can keep a roll of cloth below the baby's shoulders so that the child's head comes in the sniffing position. The rough estimate for that is baby's external auditory meatus should come ahead of the shoulder level, so that will tell us that it is in the sniffing position. Then while intubating the child, what we do is we should always hold the laryngoscope in the left hand. अगर आप लेफ्ट हैंडेड है या राइट हैंडेड है, डिस्पाइट दैट आपको हमेशा लैरिंगोस्कोप जो है आपके लेफ्ट हैंड में पकड़ना है. आप कैसा पकड़ोगे लैरिंगोस्कोप? विद thumb and these two fingers, right? And then you put on the laryngoscope blade in the on position so that you can see the bright light coming out of this tube. Then what we do is, suppose this is the baby's mouth, this is upper lip and this is lower lip. What you do is you go in from the right side of baby's mouth and go in, push the tongue towards the left side, that is towards the center, and bring this laryngoscope blade into the center, and then you go in. When you go in into the appropriate place, that time what you should be able to see is epiglottis and two vocal cords in the inverted V position. Even though right now आपको ये अभी नहीं समझ में आ रहा होगा, तो भी we'll have a video which will show you the exact procedure of intubation that will play it at the end of the talk. So when you go in and when you are intubating the child, that time you see the epiglottis and two vocal cords in the inverted V position. That time what you can do is you should never lift the laryngoscope like this. If you do this, क्या होगा कि baby का upper lip जो है वो यहाँ पे अटकेगा and you will cause trauma to the baby's upper gums. So what you should always do is ये आपको इस direction में pull करना है. ये जिस direction में आपको point कर रहा है उसी direction में आपको laryngoscope उठाना है, so that you will be able to see the vocal cords properly. Then once you see the vocal cords, what you do is you take your assistant will hand over the endotracheal tube into your right hand without looking away from this place of intubation. You should the assistant should give you the tube. तो assistant का important काम क्या है कि जो person intubate कर रहा है, he should not be required to search for the things when he is intubating the child. So आपने उसको hand over किया, So this is the laryngoscope in position and I can see the vocal cords properly. So what I'll do is ये यहाँ से side से right side of the angle of the mouth से ये introduce करेंगे and ये अंदर जाने के बाद में when you are at the level of the vocal cord you bring it in. You are not supposed to introduce the tube यहाँ center से endotracheal tube का जो ये जो blade का ये center है notch इसमें से नहीं डालना है. अगर आपने यहाँ से अगर ट्यूब अंदर डाला तो आपको खुद को दिखेगा नहीं कि वोकल कॉर्ड्स कहाँ पर है. सो आप क्या करिए यहाँ साइड से यहाँ पर आइए एंड व्हेन यू सी द वोकल कॉर्ड्स and at the tip at the entry of the laryngoscope you turn it into the center and then go in. So what you once you enter, how much we should enter we have already decided ki around 9 centimeter we had decided for say nasal septum to tragus length of 8 centimeter. Another और एक estimate rough estimate is these vocal cord guides. आपको endotracheal tube पे if you can see this in this video properly ये एक dark line दिख रहा है ये एक dark line दिख रहा है. So आपका vocal cord should be above this but below this means these two lines के बीच में अगर आपने vocal cord को रखा तो आपका tube का tip जो है it will be roughly about 2 centimeter above the carina so that you will ventilate both the lungs properly and adequately. But of course this is a rough estimate. This is not a confirmatory thing. You have to confirm the exact position of the endotracheal tube by doing an X-ray chest. We'll show you the slide also where the endotracheal tube is placed on the X-ray chest. So once you have gone in, now how do we fix the tube? Now before removing now we have gone in to the baby's trachea and this vocal cord guide has guided us to keep the tube at this level. Now what you do is with this right left index finger, you hold this tube against the baby's hard palate and you bring out this laryngoscope outside while holding the tube in position against the baby's hard palate, right? And the assistant is supposed to check for the breath sounds on both sides and heart sounds. Once you are ventilating, giving positive pressure ventilation either with ambu bag or with a T-piece resuscitator. So once you give breaths, that time you should be able to hear both on both sides breath sounds equally in axilla, both axilla. There should not be any breath sounds heard on the epigastrium. अगर epigastrium पे सुनाई दे रहा है, इसका मतलब the tube has gone into the esophagus and not into the trachea. Now once we have decided the tube is properly in place, so how do we fix it? So for fixing, we use this, as I said, pant shaped cut fixing tape. So आपको क्या करना है, ये जो uncut portion है ये tube sticking का, this should go on the cheek of the right cheek of the baby on this side, and this ऊपर का जो portion है, this will fix on the upper lip of the child like this, and the lower जो arm है इसका, it will go around the tube like this, right? So this is going on the upper lip here, this is on the cheeks, and this lower half is turned around the endotracheal tube, and this is in position now, right? Okay. Now once we have decided, how do we know that the tube is in proper position? First we said that when we do ambu bagging, that time we can hear breath sounds in both axilla. For that we need to have a stethoscope with the smallest head possible, because if you are going to use an adult size stethoscope, many times the breath sounds from other areas of chest get conducted, so you will not be able to appreciate. So a stethoscope with a neonatal head and in the axilla, uppermost part of the axilla in both sides equally should be heard. There should not be any breath sounds on the epigastrium. When during exhalation you can see the mist or vapors in the endotracheal tube if the tube is in the trachea. Of course, abroad or in the books they mention calorimetry, CO2 calorimetric test where the color turns into yellow. But many times we don't have that luxury of having calorimeter for each and every intubation. So this is the other way of ascertaining the proper position. The most important thing is if the tube is in place अगर आपका ट्यूब प्रॉपर जगह पे है और आपने अच्छे से इंट्यूबेट करके उसको बैगिंग कर रहे हो, तो बेबी का हार्ट रेट विल स्टार्ट इंप्रूविंग if we add bradycardia. The saturation will start improving, and that is the sure shot sign that the tube is in proper position, right? And I'll share the slides so that you can have look at them. So this is the indication that we all have already discussed. The equipment that we need for intubation, all these things are I have shown you just now. This is the photograph of the same thing. Then this is a chart which can be kept in our NICU for as a ready reckoner, where a gestational age or the weight and corresponding endotracheal tube size and suction catheter size, and generally the length of insertion for the respective endotracheal tube can be seen. अगर आपने ये चार्ट भी अगर बना के रखा है इजीली, तो आपको इजीली हर एक बेबी के लिए हर बार कैलकुलेट करने की जरूरत नहीं, रफली यू कैन एस्टिमेट. And we should always remember that the suction catheter that we are going to put in the endotracheal tube, जो आप endotracheal tube के अंदर जो suction catheter डालोगे, it should not occlude the endotracheal tube by more than 50 to 60%. Then if it is occluding it, then it will cause all the problems for the baby further. This is what X-ray I was talking about. So when you place the endotracheal tube at proper state.
Sir, आपके slide change नहीं हो रहे. Make it PowerPoint, share it. So it is not changing.
Just a minute. I'll do it once again. I can actually see on my computer it is being. Can you see it now? Hello? Can we see it?
Still, there's the problem. It is not in a PowerPoint mode.
सर मूव नहीं कर रही है वो.
सर नहीं, पावर पॉइंट विंडोज 7 है, शायद ऑफिस 7 नहीं है, तो इसके लिए आप अपना एंटायर स्क्रीन शेयर कीजिए सर, वो सही रहेगा. विंडो शेयर मत कीजिए, एंटायर स्क्रीन शेयर कीजिए. शेयर करते वक्त आपका हो जाएगा.
ओके, आई एम शेयरिंग माय स्क्रीन.
फर्स्ट ऑप्शन जो आता है शेयरिंग में, सबसे पहला वाला विंडो जो दिखता है वहां पे शेयर कीजिए, उसको शेयर कीजिए.
ओके, अभी दिख रहा है?
हाँ, ये दिख रहा है. अभी आप पावर पॉइंट प्ले कीजिए एक बार.
हाँ.
करो.
Is it moving now?
No.
आप नहीं सर, नहीं, वो दिखते वक्त यहाँ पे नहीं दिखा रहा.
एक मिनट.
हाँ सर, अभी आ रहा है.
अभी आ गया ना?
अभी आ गया. हाँ जी.
ओके. हाँ, तो अर्लियर स्लाइड्स वेर नॉट सीन, नो?
नहीं, पिछले वाला नहीं दिखा रहा सर.
No, it is not moving here. Okay, this is the X-ray. जहाँ पे आप देख सकते हो कि ये टिप है एंडोट्रेकियल ट्यूब का, and this is the T1, that is thoracic first vertebrae, and this is thoracic second vertebrae, and this is carina, where you can see that the trachea is getting divided into 2 bronchi, right? Now, no, this is not moving on my this thing, my PC. अभी हो रहा है मूव सर?
नहीं सर, नहीं हो रहा है। अब एक काम करेंगे सर, आप जो है ना उसको पावर पॉइंट स्लाइड शो से निकाल दीजिए और आपका जो जूम है ना नीचे वाला, उससे आप 100% कर दीजिए, तो आपका स्लाइड बड़ा दिखेगा। आप उसी स्लाइड को मूव कीजिए। मोस्ट राइट साइड में जो नीचे दिखता है ना, पावर पॉइंट के बाजू में एक जूम का ऑप्शन है आपको, जहाँ से आप पावर पॉइंट प्रेजेंट करते हैं ना, जहाँ से पावर पॉइंट प्ले करते हैं आप, उसके राइट साइड में देखिए, वहाँ पे एक ऑप्शन है 69% अभी दिखा रहा है अभी आपको वहाँ पे।
69
झूम इन एंड झूम आउट असतं ना, दॅट सेम वन, प्लस मायनस साइन आहेत त्याच्यामध्ये.
खाली राइट साइडला तुम्ही सर स्क्रीन
See,
शेअर
what I can see is share screen, then record reactions.
पॉवर पॉइंट मध्ये आम्ही म्हणतोय, तुम्ही स्क्रीन
पॉवर पॉइंटच्या एक्झॅक्टली बाजूचं बटन पाहते ते स्केल प्लस मायनसचं स्लाइडची साईज.
सर तुम्ही स्क्रीन शेअर करा एक मिनिट.
हा मी करतोय,
स्क्रीन शेअर करा.
हा हे काय, हा 69 दाखवतंय, त्यातलं काय?
हा ते ना ते वाढवा, म्हणजे तुमच्या स्लाइड्स मोठ्या दिसतील दिसायला.
ओके, हा दिस इज 100% ना.
आणि ह्या सरळ ह्या स्लाइड शेअर करा, कारण ते आपल्याला दिसत नाहीये पॉवर पॉइंट प्रेझेंटेशन, तर ह्या स्लाइड तुम्ही शेअर करा डायरेक्ट, असं म्हणायचं होतं आम्हाला.
आता याच्यात शेअर स्क्रीन करून करायला लागेल ना.
हा शेअर स्क्रीन करा ना सर प्लीज.
राईट, आता याच्यातली बरोबर.
येस, दिसतंय का?
आता दिसतंय.
हो सर, स्लाइड मूव होतात का चेक करा.
मूव होत आहेत का?
लेफ्ट टॅब वर फक्त क्लिक करून तुम्ही स्लाइड नेक्स्ट खाली डाऊन एरो बटन दाबलं,
स्लाइडला फक्त
मी
खाली
करतोय.
करा.
तर सध्या माझ्या इथे मूव होत आहे. याच्यात होतंय का? तुम्हाला दिसतंय का मूव होताना?
नाही, नो.
नाही.
एक काम करा सर,
हा
तुमचं प्रेझेंटेशन ना यांना पाठवा ना, मेल करा कुणाला तरी. बरं,
कोणाला मेल करू?
टेक्निकल टीमला त्यांना मेल करा, त्यांचा मेल आयडी घ्या. दे विल मूव द स्लाइड्स, त्यांच्याकडनं शेअर करतील स्क्रीन. यू जस्ट गो ऑन लाईक टॉकिंग.
ते करता येईल किंवा सर तुम्ही, अच्छा ओके,
तुमचा मेल आयडी द्या ना सरांना लवकर, पटकन.
हा मी मेसेज करतोय.
ईमेल आयडी द्याल का मला?
सर हॅलो. हा सर, माझा घेऊ शकता, ए dhongde1@gmail.com.
जस्ट अ मिनिट. ए
dhongde
DHONGADE
1@gmail.com.
आता दिसतंय का हे मूव होताना? हॅलो,
शेअर नाही सर, स्क्रीन शेअर नाही.
स्क्रीन शेअर नाही तुमच्या.
दिसतंय का स्क्रीन?
नो सर, बेटर लाईक वन्स युअर मेलिंग, आशिष सर विल ओपन इट. नो प्रॉब्लेम.
या आय एम ट्राइंग टू डू दॅट. अरे ते स्क्रीन शेअर होत नाहीये.
सर ईमेल पाठवलंय का?
हो मी पाठवतोय, एकच मिनिट.
Sir, we have another talk on ventilator, so we have to wind up.
Yeah. I have sent it, sir.
Okay, I still have not received it. As soon as I get it, I will. Yes.
मिळालंय?
Yes. No. Gancham, can I share screen?
Yes, sir. Yes, sure.
Is it moving?
It
Yeah.
is.
It is not centralized, but
Is this okay?
It is good to go.
Yeah, okay. Yeah.
Okay, sir, tell me as you want to change the slide.
Yeah, please go ahead. Go down.
Next.
Down. Go down further. Again, one more. So this was the chart I was talking. ये आपके NICU में you can keep ready as a ready reckoner for deciding the appropriate size of the tube, length of insertion, and the size of the suction catheter that we are going to need. For the next slide, sir. So this is a video. We can see it at the end. We'll go down further, sir. I just want to show this X-ray we had decided. We have done this X-ray to check the site of the. Sir, the slide has moved. Yeah. So this tip of the ET tube can be seen at in between T1 and T2, and carina is at this T5, T6. So this should be the appropriately placed endotracheal tube. Next slide, please. So this was the this we have already discussed. How do we know that the tube is properly placed? Next one, sir. And the fixing of the endotracheal tube also we have seen. We'll see it in the video also. Next one. So what is the role of the assistant and the intubator? So when the intubator is when we have decided to intubate a child, he will request for the appropriate size of the tube, laryngoscope blade, and whether he'll want to use a stillet or not, he'll tell. The assistant will ensure that the suction pressure is set at 80 to 100. He'll select the proper size tube and the laryngoscope blade, and he'll check whether the laryngoscope is working. All these things we have already seen. Next slide one. And during intubation, the person who is going to intubate, he should not move his vision from the field of vision. So the assistant gives the proper sniffing position, monitors the heart rate, and he will keep a watch on the time also. अगर आपका intubation का time is going to be more than 30 seconds, you should tell the person who is intubating that you are exceeding the time, so that you can again give positive pressure ventilation with bag and mask, and then come back to the second attempt. Next one, sir. So this is a ET chart which should be kept for each and every child who is intubated, where you write the name of the child, his age, sex, gestational age, weight of the baby, date of birth, and intubation date, and the endotracheal tube ka size, what you have used, where is it fixed at, and if you go further down in this slide only, you can see the slide is not fully visible, sir. Okay, इसके नीचे ये है कि what suction catheter size you have used and to what length you are going to insert. So अगर आपने ये चार्ट बना के वो बेबी के बाजू में रखा, and by mistake the tube gets dislodged and you have to re-intubate the child, you don't have to do this procedure. आपको बार बार करने की जरूरत नहीं है. This will be a ready reckoner for that particular baby. So every child who is intubated, we should have this kind of a chart which is made and stuck near somewhere on the wall near that baby. Sir, we can play the video if the time permits.
Okay.
Yeah.
I'm just trying. I'm not able to play the video. I don't know.
Okay, I'll share the video on the group also, so that everybody who wants to watch then can watch.
Okay. Okay.
Stop.
So, sir, can we then continue with the next talk?
Yeah, please do that. Yeah, thank you. Thank you. Thanks a lot for the opportunity.
Thank you, Kaushik sir. Actually, it was very elaborative, nice. Like there are some technical issues, but no issue. You can share that video with the others, and we can share on the WhatsApp group also. So the next speaker for us, she's there going to speak is Anu Matthew, and she's nurse in charge at Fortis currently, and she's going to speak on the nursing care of nursing care plan for ventilated newborn. So, sister, please go ahead.
Good evening, all. Am I audible?
Yeah.
So, good evening, all. The capacity to care is thing which gives life its deepest significance. A wonderful thought by Pablo Casals. So, I would like to start my session with this wonderful video. So, today's topic that I'll be covering is nursing care plan for ventilated neonates. Myself, Teacher Anu Matthews, the nurse in charge, Pediatric and Neonatology Department, Fortis Hospital, Mulund, Mumbai. I'll be taking you all through the routine of a nurse when she comes for her duty, whether it is a ventilated baby or whether she is having a preterm baby, but what all are the routines that she will be looking after, starting with the nursing handover, the neonatal head-to-toe assessment, cluster care, monitoring, ongoing assessment, identify deterioration, VAC prevention, documentation, and nursing care plan. Now the nursing handover. As all the nurses are familiar in this group, the nursing handover should be taken in the format of ISBAR or SBAR. ISBAR या SBAR, इसमें से कोई एक फॉर्मेट में ही हम हमेशा नर्सिंग हैंडओवर देते हैं. इसके बारे में एक डिटेल एक्सप्लेनेशन की जरूरत नहीं. अभी नर्सिंग हैंडओवर में 3 टाइप्स के हैंडओवर होते हैं: पेशेंट हैंडओवर, डॉक्यूमेंटेशन एंड बेडसाइड. What all are the things that includes in the patient handover? The patient handover includes the disease condition, the laboratory test, the present condition of the patient. Then what all are the further proceedings that we'll be doing for the patients. All this will include in the patient's handover along with the physical examination and the assessment. What all comes under documentation? The documentation includes the monitoring charts, the assessment charts, what is the plan of action that we are going to take forward that we can get from the doctor's progress notes. Further comes which is an important part for a nurse, that is the nursing progress sheets. After completing that, we'll come forward. Once we have done with the patient's handover, patient का handover हमने पूरा ले लिया, documentation भी हमने पूरे देख लिए, फिर उसके बाद आएगा अपना bedside handover. Bedside handover में हम क्या क्या देख सकते हैं? Patient के lockers, yes, patient के lockers में patients के medicines रहेंगे, जो diluted medicines है तो वो रहेंगे, नहीं अगर oral syrups है तो वो रहेंगे, उसके ऊपर के date of openings, date of expiries, all the medicines timely. अभी मेरे 8 hours के duty में मुझे जो भी medicines देना है, whether those medicines are available or not, for check for the availability. Then the consumables. For my neonate, what all are the consumables required? Whether those consumables are available in the patient's bedside. Now, the assessment should be done at the time of handover in the presence of both staff along with the cluster care. This is something the most important part that I would like to highlight. अभी मैं evening duty में आई हुई staff हूँ, तो मुझे morning duty के staff के साथ the first assessment of the patient वही time पे करना चाहिए जब previous shift के staff मेरे साथ हैं, और वही time पे the cluster care, पहला cluster care, मेरे duty का first cluster care तब होगा जब मेरे साथ previous duty के staff रहेंगे. अब cluster care में क्या क्या हम कर सकते हैं patients के? Ventilated patients हैं तो हम suctioning कर सकते हैं, patients के positioning change कर सकते हैं, patency of the line change कर सकते हैं, patency of the line हम check कर सकते हैं. अभी क्लस्टर केयर जो है वो एवरी 2 to 4 आवर यूजुअली हम बोलते हैं कि वो करना चाहिए, बट इफ द सिक नियोनेट्स, if we are having a sick neonates with us, it depends upon the doctor's orders. Every 1 hourly चाहिए तो 1 hourly भी हमें वो करना चाहिए. Now, specific surgical instructions in post-operative patients. Post-operative patients में हम ये जो routinely handovers लेते हैं वही काफी नहीं. पोस्ट ऑपरेटिव पेशेंट्स में पेशेंट के सर्जिकल साइट्स का हैंडओवर लेना पड़ता है, पेशेंट के एनबीएम का स्टेटस जो है उसका हैंडओवर लेना होता है, आईवी फ्लूइड्स है, पेशेंट्स के अगर फीड स्टार्ट किया है तो उसका हैंडओवर, ऐसे स्पेसिफिक हैंडओवर्स हैं जो पोस्ट ऑपरेटिव पेशेंट में होना चाहिए, तो वो वेरी स्पेसिफिक हैंडओवर भी हमें लेना चाहिए. Then comes the disease specific handover in babies with HIE, seizures, PPHN, etc. इसमें अगर एक एग्जांपल देना चाहूँ तो सीजर्स वाले भी, अभी एक प्रीटर्म बेबी मेरे पास है तो ऑब्वियसली मैं वो प्रीटर्म बेबी के लिए I will not have asked the previous staff as for whether the baby was having any episodes of convulsion. No. But for a seizure baby, obviously I will have to answer that question, whether the baby was having any episodes of convulsion. If she says no, then the further question will be, when was the last episode of convulsion? So disease specific handover, it is very important for a nurse when she is taking a handover. Then comes the assessment. What is assessment? Assessment का मतलब क्या होता है? Assessment means it is an ongoing systemic collection of data. वो एक systemic collection of data होता है जिससे हमें क्या क्या पता चलता है. Clinical conditions, patient के clinical condition में क्या changes हुए हैं वो पता चलेगा. फिर response to therapy, हमने जो therapy patients को start किया है वो therapy में क्या क्या changes है, we can come to know about that. Then the interventions, क्या क्या interventions हमें आगे करना चाहिए, what we need to plan, all those we can get through the assessment. Then comes, it also helps in redefining patient's care needs. Patient care needs के बारे में हमें पता चलेगा. Therapies अगर कुछ proposed है तो उसके बारे में हमें पता चलेगा. Prognosis, what is the prognosis of the patient? Patient's education. Actually for the neonates, it will come as parents' education. What is the parents' education regarding the prognosis or the disease condition of the neonate and the discharge planning? As we all know, the discharge planning starts from the day or from the time the patient is admitted in the hospital. Next comes the neurological nursing monitoring. Neurological nursing monitoring में ये 5 monitoring हमें करने चाहिए, but that too depends upon the availability in your unit. हमारी unit में जो available है उस हिसाब से हम monitor कर सकते हैं, but monitoring करना बहुत ही important है अगर कोई neurological condition का patient हमारे पास आ रहा है. That includes stages of encephalopathy, SARNet staging, which we do in HIE, neonatal sedation and pain scale, CFM monitoring and nurse monitoring, that is for low cardiac output. अभी इन डिटेल अगर हम सार्नेट स्टेजिंग के बारे में अगर हम देख रहे हैं तो इट इज डिवाइडेड एज कॉन्शियसनेस ऑफ द पेशेंट, द एक्टिविटी, न्यूरोमस्कुलर कंट्रोल दैट इंक्लूड्स मसल टोन, पोस्चर, स्ट्रेच रिफ्लेक्सेस. प्रिमिटिव रिफ्लेक्सेस में आएगा सक, मोरो एंड टॉनिक रिफ्लेक्स, टॉनिक नेक. Then comes the autonomic functions, which includes the pupils and the heart rate, and lastly the seizures. It is divided into 3 stages: stage 1, stage 2, stage 3. This all depends upon the assessment. How do we do the assessment of the patient? Accordingly, we need to do the charting. Then next comes the neonatal sedation and pain scale. If the neonate is sedated, then we need to do the sedation pain scale. If no, then only the pain scale, that is NIP scale, that is neonatal infant pain scale. Now in that, cry irritability, what all do we assess? What is the criteria that we need to assess in the sedation and pain scale? That includes cry irritability, behavior state, facial expression, extremities tone, vital signs, which includes the heart rate, respiration, blood pressure, and the oxygen saturation. So depending upon the patient's condition, we need to do the charting over here. Moving further, this is something a most important part a nurse should know, or this is something a most important part where a nurse should have a vital role in preventing infection. That is cluster care that we provide every 4th hour or 2nd hour. 2nd hourly or 4th hourly cluster care जो है वो हम provide करें तो as per my experience, we can avoid a lot of infections if we do it properly, or a lot of damages that can occur to a knee. It includes the position of the patient, chest leads positions, then prop position, NIBP cuff position, diaper care, ventilator care plans, checking patency of IV line, sugar check, abdominal girth monitoring for feeding schedule, then administration of medication. Patient's positioning, as you all know, the position of the patient should be either supine or prone, and according to the disease condition, it can also be as lateral. But it should be done in the cluster care every 2nd or 4th hour. Leads position है कि हम हर एक टाइम पे जब भी क्लस्टर केयर दे तब लीड्स का पोजीशन हम चेंज करें. इट इज नॉट इम्पोर्टेंट, बट अ नर्स शुड बी विजिलेंट इनफ कि उन्हें पता चलना चाहिए कि जो लीड्स लगाया है वहां पे कुछ रेडनेस, रैशेस या कोई स्किन पील ना. Prop position, obviously the prop position has to be changed for each and every time whenever we do the cluster care. The NIBP cuff position also needs to be changed. The diaper care, that is the most important part that we need to do. Then comes the ventilator care. Ventilator care में हम क्या क्या देख सकते हैं? पेशेंट का सक्शनिंग हम कर सकते हैं, वेंटिलेटर मॉनिटर्स पे जो सेटिंग्स है वो हम चेक कर सकते हैं. द सर्क्यूट्स, वेदर देयर इज एनी प्रेजेंस ऑफ वाटर इन द सर्क्यूट्स, वो हम चेक कर सकते हैं. ह्यूमिडिफायर, whether the water level in the humidifier is appropriate on. All those things we can check in the ventilator care plan. Checking patency of the IV line, yes, it is most important. अगर हमने IV line के patency check नहीं की, then there is chances of phlebitis, extravasation and all such complications. So we have to check the patency of the IV line. अगर हम IV line check करते दौरान कुछ भी हमें resistance लगा, stop it over there. What all is the therapy going on? Keep it on hold. Inform the doctors immediately. Then sugar check as and when recommended. Abdominal girth if the feeding is scheduled. अगर बच्चे को feeding जा रहा है तो it is very important that we need to check the abdominal girth pre-feeding. Feeding से पहले हमें abdominal girth check करना चाहिए. अगर उसमें कुछ भी variation हमें लग रहा है, if the abdominal girth has increased, then we need to keep the feed on hold and inform the doctor accordingly. Administration of the medication, if during the time of cluster care अगर मेडिकेशन भी इंक्लूड हो रहा है और there is a dosage of the medication at that time, provide the medication also, complete the cluster care and leave the baby alone for 2 to 4 hours or till the next time when the baby cries. Now there is a small confusion in this, like cluster care हम time schedule देते हैं. मैंने 2 hourly बोला तो morning 8 o'clock को दिया, next cluster care आएगा next 10 o'clock को. In between अगर बेबी ने डायपर वेट किया तो ऐसा नहीं होना चाहिए कि अगर 9:30 को बेबी ने डायपर वेट किया तो वो डायपर हम चेंज करें और नेक्स्ट क्लस्टर के 10 o'clock का टाइम है बोल के टिल 10 o'clock वेट एंड देन वी गो फॉर अ क्लस्टर. नो, इट इज नॉट recommended. Minimum handling of the baby. So for that, if 9:30, if the baby's diaper is getting wet, at the very same time we can give the complete cluster care to the baby and keep the baby free, and the further timing we can adjust accordingly, whether we can make it as 11:30 or 12. Moving forward, suctioning. The major part of the suctioning sir has covered, but even then I would like to give some highlight on this. That is, suctioning, it is a procedure. Yes, it is not that ventilated patient है suction करना है, ऐसा नहीं है, वो एक procedure है. तो प्रोसीजर के लिए सबसे पहले हम एक रेडीनेस होता है प्रोसीजर का, उसका प्री ब्रीफिंग होता है, प्रोसीजर होता है, उसका पोस्ट ब्रीफिंग होता है. तो सक्शनिंग के लिए हमें क्या क्या जरूरी है, ऐसा नहीं कि हम आए सक्शन कैथेटर लिया, सक्शन किया, बस हो गया. नो, we have to check for availability of all the things and working condition of everything. So for the readiness of suctioning, we'll have to see whether the suction pressure is maintained between 80 to 100 mm of mercury. इतना उतने पे ही सक्शन प्रेशर रखना है. प्री ऑक्सीजनेशन करना है सक्शन करने से पहले. एम्बूबैग अटैच विद O2 ट्यूबिंग. एम्बूबैग O2 ट्यूबिंग और रिजर्वायर के साथ अटैच रहना चाहिए विद अप्रोप्रिएट FIU. सक्शन कैथेटर का अप्रोप्रिएट साइज दैट इज 6 to 8. नियोनेट्स में 6 to 8 साइज का सक्शन कैथेटर हम चूज करते हैं विद द सक्शन ट्यूबिंग्स अटैच्ड इन इट एंड फॉर द चेकिंग ऑफ द सक्शन apparatus whether it is in working condition or not. Checking of all the articles जो हमें चाहिए था वो हमने किया. Then after that we'll be moving forward towards the suctioning process. So as it is a process, as I told you all previously, it is a procedure. So aseptic precaution has to be maintained 100% for this. This maintaining an aseptic procedure for any of the technique, that is the first and foremost thing where we can prevent infection. Infection of catheter as per the ET length. Sir has explained you all about this, that ET length के हिसाब से हमें suction catheter का साइज मेजर करना है और नेगेटिव प्रेशर को अवॉइड करते हुए हमें वो सक्शन कैथेटर इंसर्ट करना है. इंसर्ट करने के बाद स्क्रूइंग बिल्कुल नहीं करना है. हाइपोक्सिया अवॉइड करना है. इफ एट ऑल वी सी patient is going into hypoxia, directly take the patient to for ambuing, and after that connect the once the patient is stable, connect the patient to the ventilator tube. सक्शन कैथेटर हमने इंसर्ट किया, फिर जब हम विड्रॉ कर रहे हैं उस टाइम ऐसा नहीं होना चाहिए कि हम डायरेक्टली विड्रॉ करें. Always withdraw it in rotatory motion. Then avoid saline unless indicated. Unless and until secretions इतने thick हो कि हम suction करें और secretion नहीं आ रहा है, only then with the advice of the doctors we can use the saline, or else we should avoid that. Then the major part, that is the oral care. For all the patients it is compulsory to provide the oral care. For neonates we can give it with a sterile gauze dipped in the distilled water or expressed breast milk. That is done every 4th hour. That means it is also a part of clustering. Then comes open suction versus closed suction. Open suction का डिटेल मैंने अभी आपको बताया. क्लोज सक्शन और ओपन सक्शन में डिफरेंस इतना ही है कि ओपन सक्शन के दौरान हम वो वेंटी का ट्यूबिंग डिटैच करके हम पेशेंट को सक्शन करते हैं जहाँ पे एम्बू वगैरह जरूरी पड़ती है. बट क्लोज सक्शन में इट इज नॉट रिक्वायर्ड. पेशेंट इज नॉट डिटैच फ्रॉम द वेंटिलेटर. Beside that itself, we can do the suction. Now, cardiovascular monitoring. In the cardiovascular monitoring, say in the red lines itself, it is highlighted that alarms are meant to alarm. Yes, alarms क्यों दिया जाता है? ताकि हम उससे हमें वो alarm मिले कि something is going on wrong with my patient. Set age appropriate and clinically accepted alarm limits. Always हमें age appropriate alarm limits पता रहना चाहिए, तभी हम वो अलार्म लिमिट सेट कर सकते हैं. If we are not clear on it, we can have a cross check with the doctors available on duty. Check alarm limits at the beginning of your shift. मैं अभी इवनिंग ड्यूटी के लिए आई हूँ, पेशेंट को मैंने हैंड ओवर लिया. Just after that, go to call the doctor and ask them what is the accepted alarm limit for this patient. अगर कौन सा अलार्म लिमिट है जिसके बीच में ये पेशेंट को रख सकती हूँ. अगर उसे क्रॉस किया and we find an alarm, that means something is going wrong with the patient and we need to immediately inform the doctors. Turn on volume in sick children, as noise can lead to hearing impairment. Yes, अगर sick child है, हमें लग रहा है कि patient deteriorate हो सकता है या फिर इसमें fluctuations होते हैं, only then keep the alarms on, or else बच्चे को hearing impairment, it is very dangerous. Then monitors in the monitors, यहाँ पे जैसे images दिए हैं वो image में आपको दिख रहा है. Monitors में हम क्या-क्या हमें monitor करना चाहिए? That is heart rate, respiration, blood pressure, oxygen saturation, that too pre and post ductal as indicated. ये सब हम देख रहे हैं. उसके बीच में एक चीज है जो हमसे नहीं छूटना चाहिए, वो that is a very good waveforms. अगर वेवफॉर्म्स प्रॉपर नहीं आ रहा है और बच्चा मुझे ब्रेडी में दिख रहा है या फिर ऑक्सीजन सैचुरेशन ड्रॉप होता हुआ दिख रहा है and the waveforms are not good, what is the indication for that? That means the chest leads are not attached properly. या फिर ऑक्सीजन का पोर्ट जो है वो प्रॉपर्ली अटैच नहीं होगा. So do that first if the waveform is not proper. If the waveform is proper and you find any deterioration, immediately call the doctor. Don't wait for checking of the probes or the chest leads. Now ventilator setting. As in monitor setting, I have told you, set all the alarms as per the age, weight and disease with the consultation from the doctors. Be vigilant. One bedside nurse, one bedside intensive care nurse इतनी vigilant होनी चाहिए या फिर इतना intelligence उसमें होना चाहिए कि जो भी deterioration हो रहा है patient को उसके बारे में वो जल्दी catch कर सके, because 24/7 it is not necessary that doctors need to be available with the bedside. So she should be that vigilant enough or that intelligent enough that she catches off any of the changes that comes in the settings and she informs the doctors accordingly. Biochemical monitoring is done by doing ABG. Yes, ABG से biochemical monitoring होता है, but that too as per the prescription of the doctors. After besides all this monitoring, never forget to monitor patient clinically. Patient को clinically हमेशा monitor करना चाहिए. That comes as a part of our assessment. Now, nursing care plan for a ventilated child. एक ventilated child में हमें क्या-क्या देखना चाहिए? That is artificial airway patency, breathing and extubation prediction. In artificial airway, we can see for the placement of the tube, whether the tube is placed properly, whether the tube is secured properly, and what is the status of the cuff, whether it is inflated or deflated. Now, air patency. In the airway patency, we can see for the suctioning to assess the lung secretions, adequacy of humidification. In breathing, we'll go through the respiratory rate, graphics, pulse oximetry, capnometry, and ABG analysis. Next comes the extubation predictor that includes the ET leak. What is the amount of ET leak that we can see in the ventilator settings? How is the cuff, gag, type, amount, and nature of ET secretions. There are some monitoring when the patient is on ventilator that we need to do on hourly basis, which includes the mode of the ventilator, what is the set FiO2, what is the tidal volume, respiratory rate, MAP, PEEP, PIP, and the leak. This monitoring is to be done on hourly basis. Next comes the nursing care plan checklist for a ventilated patient every 4th hourly. Yes, this checklist has to be maintained every 4th hourly. अगर 4th hourly ये checklist हमने maintain किया तो कुछ भी हमसे miss नहीं होगा और nothing can be a cause from our side so that a deterioration occurs to a patient. That includes alarm limits, whether the alarm limits are checked on. Air patency हमने check किया है या नहीं किया है. Air entry equal है या unequal है, उसके लिए हमने check किया है. ET tape is strapped or unsecured. Comfort, baby को comfortable है या नहीं है. Then if the baby is sedated or getting sedation, whether the baby is well sedated or not, whether we can see any signs of shock, or whether there is any feeding intolerance if the feed is started for the babies. Nextly comes the VAB bundle. This is a major part where the nurses play a vital role in preventing a VAB if we go through a proper VAB bundle care. In this, it is divided into two, before intubation and post-intubation. Pre-intubation, the first line you all can go through is the clinical care team should have a proper justification for the intubation and ventilation. Yes, without having a proper justification, the intubation and ventilation we cannot. Then comes the aseptic precaution. As I've told previously also, everything is a procedure. Intubating a patient is a procedure, doing a suctioning is a procedure. So aseptic precaution has to be maintained. Post-intubation, what all are the things that we'll go through? This chart is been maintained in every shift and every second hour. Then comes daily evaluation for the readiness of extubation. Yes, the nurse should always be ready for an extubation process or a reintubation. Then comes hand hygiene, strictly to be done only. The bedside nurse, she is the whole and soul of the patient. If any healthcare assistant or healthcare professional come to the patient, or if the doctors come to the patient to examine the patient, it is the role of a nurse who is standing the bedside to see for the 100% compliance of hand hygiene. That is the first and foremost thing where we can prevent.
Last 5 minutes. Last 5 minutes.
There we can prevent infection. Then what is the neonatal head high position? That is 15 to 30. Strict sterile gloves has to be worn while we handle the ventilator tubings and suctioning. The suctioning has to be done in aseptic precaution. Pre-oxygenation has to be done. The vented circuit water has to be removed every 4th hourly, and the mouth care, as I've told previously. Then comes the documentation part. In the documentation part, the flow sheet, the treatment sheet, the nurse's notes, the WAP bundle care plan, nursing event sheet, investigation chart. Besides this, इसके सिवाय भी diabetic chart होता है, investigations chart होता है. Many more are the documentation that a nurse has to maintain, and before and every hour timely basis. Now WAP bundle has to be done 2nd hourly, so it has to be done 2nd hourly. It is not that at the end of the shift, all the nursing, all the chart is being filled together. No, it is not. That is not the way to work. Yes, no. So bedside nurse jo hoti hai, so she has to be that vigilant that she does the monitoring properly, because if she does the monitoring properly, only then she'll do the assessment properly. Assessment किए बिना वो ऐसे ही जाके 2 hourly monitor नहीं कर सकती. If at the end of the shift if she is going and trying to fill all the columns, that means she is not seeing the patient and she is directly going and doing the charting, which is not recommended. Then comes the nutrition and metabolic and renal monitoring, which includes the enteral and parenteral nutrition. Enteral nutrition में अगर feed start है patient को, तो pre-feed aspirate करना चाहिए. Pre-feed aspirates में हमें color और volume of the aspirates हमें पता चलेगा. Abdominal girth, if there is any changes in the abdominal, whether the abdominal girth has increased or decreased. By auscultation, we can come to know regarding the bowel sound. Stooling, abnormal mass का कुछ प्रेजेंस है तो वो भी हमें पता चलेगा. फीड अगर हमने बढ़ाया है तो फिर हमें इंटॉलरेंस कुछ है तो उसके लिए हमें ध्यान रखना है. उसी तरह से फोर्टिफिकेशन में भी, इफ वी आर डूइंग द फोर्टिफिकेशन, वी शुड नो रिगार्डिंग द इंटॉलरेंस और वी शुड मॉनिटर रिगार्डिंग द इंटॉलरेंस. In the parenteral nutrition, the TPN and PPN, which includes carbohydrates, lipids, proteins, electrolytes, and sugar. During that, what all are the monitoring we need to do? That is sepsis, electrolyte imbalance, renal function test, lipid profile, and the sugar intolerance. Then comes for the sepsis monitoring. First, before taking you all through the slide, I would like to add on one thing. We are looking for the sepsis monitoring, but one thing we can think on, if we do a proper hand hygiene or if we maintain an intensive care protocols properly, then how can there be a chance of sepsis? Sepsis का तो वहाँ पे कोई सवाल ही नहीं होता है. So work hardest to prevent. Hand hygiene 100% कराओ या फिर खुद करो. Then gown and cap as per unit protocols. Antibiotic chooses as per the unit protocols. Device stewardship. How often do we clean our devices? What are the unit protocols that we need to follow? Or what all are the things that we use for the cleaning of the devices? Now, prefer non-invasive support over invasive support, because obviously non-invasive support, through non-invasive support, there are very minimal chances of infection. Now, after seeing all these things also, if at all the baby gets sepsis, watch for the complications of shock and multi-organ dysfunction. Do not forget to remind doctors for antibiotic stewardship. Yes, if the baby is on long-term antibiotic, being a nurse, it's our duty to remind the doctors regarding the total number of days on which the baby is on antibiotic. Remind the role of prophylactic antifungal therapy. If the baby is on long-term antibiotic more than 18 to 20 days, then it's our duty, being a nurse, being a bedside nurse, it's my duty to remind my doctor that since so many days the baby is on antibiotics, so can we please start the baby on any antifungal therapy as a prophylactic basis. After that, monitoring environmental infection risk factors. Environmental infection risk factor, अगर हमने environment को properly infection से free रखा, so अगर ऐसा किया तो फिर prevention is always prevention will always be a good sign more than curing a patient. For the environmental safety, what all the other things that we can see? The room cleaning, the intensive care ka room cleaning, how oftenly we need to do? How oftenly we need to take the swabs so that we can find for any growth? How oftenly we do the wall cleaning, and what all are the chemicals that is being used, and whether the cleaning is being done properly or not. Then coming to the social economic monitoring of parents. Nurse has a better rapport with parents. Yes, nurses को parents के साथ हमेशा एक बहुत अच्छा rapport होता है. Parents बहुत ज़्यादा nurses के साथ open up होते हैं. तो एक NICU nurse जो है वो सिर्फ एक patient को treat करने के लिए नहीं वहाँ रहती, हमेशा एक parents को एक support के तौर पे उसके साथ खड़ी रहती है. Or venting out and helping parents to cope with the ongoing problems. Yes, with having a good rapport or with having a good communication, she always helps out the parents to cope up with the ongoing problems. Red flag parents should always be diverted towards the doctors or should always be sent towards the doctors so that all their confusions get changed. Update only medical facts. Hear more with compassion, but do not false assure. Always be the part of daily counseling and speak on the same line. Yes, this is more important. बेडसाइड में जब जाती हैं तो नर्स एक इन्फॉर्मेशन दे, डॉक्टर्स जब अपडेट करने के लिए आते हैं तो वो एक इन्फॉर्मेशन दे. दैट शुड नॉट बी द वे. द पेरेंट शुड गेट द इन्फॉर्मेशन फ्रॉम ऑल द साइड इन अ सेम लाइन so that there is no chance of any confusions created in their mind. Identify violent behavior and update hospital advice. Now, breaking up of bad news. Spike protocol can be used for breaking up of bad news. In that, S stands for setup. There should be a comfortable place provided to them, the noise-free atmosphere, so that they can be calm and quiet, sit beside the patients. P means perception. In that, just ask them, what all are the things that you know about the illnesses? उन्हें illness के बारे में क्या-क्या जानकारी है, उनको पहले पूछो, उनको vent out कर लो. After that, I stands for invitation. Just after that, after knowing all the knowledge regarding the disease condition, ask them that what is more further you all would like to know about this disease conditions. Then knowledge. Provide knowledge and information to the patient. E means emotion. Address the patient's emotion and provide empathetic support to the patient, which is most important part where a nurse or a doctor can stand beside the parents. Now, this is a take-home message or what I have learned from you. Always prevention is better than cure. If there is a strict infection control practices, if being a bedside nurse, I am having a good observation. Based on the observation, if I am doing a good assessment, based on the assessment, if a well planning is there in my mind and I implement all those whatever I have planned, then in the evaluation I can get a good result that I send the baby home with the parents happy. With this, I would like to wind up my topic saying, sometimes I inspire my patients, more often they inspire me. Thank you.
Thank you, sister. Gentlemen, both speakers were very good. Kaushik sir has covered technical aspects in detail and sister has covered nursing part very well. It was actually a good learning lesson for all the delegates who have joined here. If they have any questions, please go ahead. You can ask. You can type the question in the chat box.
Yes, thank you, Dr. Sunil, for your expert comments. And yes, I agree with you. Both the talks were excellent. Sister Titu Anu Matthews, as well as Dr. Kaushik Fanish. Thank you very much for making your talk so simple and practical and very easy to understand for all the nurses. So thank you very much for your talks today. So yes, I don't see any questions in the chat box. So our next session on nursing education is going to be on the 10th of June. So it's going to be on lactation, lactation counseling. Will be one talk and the other one will be on neonatal septic shock. So both the talks again are very practical oriented and so we'll see what the nursing care is to be taken during those two talks. So I thank you everyone. Thank you all the viewers. Thank you Dr. Sunil again for being the expert for this session. And with this, I would like to close this session. Thank you very much.
Thank you, everyone. Shalom, bye.
Thank you. Thank you.